Hello and welcome back to another Polestar Pilates Hour. It is great to be with you again. I heard you guys had an awesome time with Shelly Power last week, as usual and as expected. Today, as you know, we're going to be talking about the snapping hip syndrome, and we are setting and breaking all kinds of records today. Today, we're going to be talking about a snapping hip case, and I hear this complaint all the time, and especially working in the dance medicine world. The snapping hip is a very, very common problem. And basically, 99% of the time, it is the iliopsoas tendon that gets inflamed. And instead of being nice and flat, it becomes round. That's what inflamed tendons do. And it rolls over the joint or the capsule of the hip. And so anytime you have a long lever or you're reaching your leg up in the air or you're doing something like the 100 or teasers or leg circles, that they often will complain of a snapping hip. And that's just the tendon rolling over. Now, we hear these snaps all the time in our bodies. We hear them in our ankles, in our knees, in our hips, in our shoulders, right? In our neck, we can hear those snapping tendons sometimes. So it's not uncommon, and it's not always a problem. But in this particular case, it is. So Lena is our guest today, I guess. She is a 49-year-old female retired professional dancer. She recently completed her Pilates certification and has been dealing with a snapping hip for a while, but has been formally diagnosed with a snapping hip syndrome. And symptoms include things like anterior hip pain, muscle guarding around the hip, and chronic snapping of the right hip with any kind of long lever hip flexion, which you know if you do a lot of Joseph Pilates' original mat exercises, you're going to be using that long limb against gravity, and that tends to be one of the greatest aggravators of snapping hip syndrome. I'm sure if I did a little shout out and just inside the chat, how many of you have actually experienced snapping hip in yourself or a snapping hip syndrome with one of your clients? I'm pretty sure that we'll see a large number of us that have had that, and me included. So some of the aggravating factors for her, yes, indeed. I see that all over the place. So there's like 100 of you on, and I just got like 100 answers in the chat. So it's pretty popular. I'm sure that's probably why a lot of people wanted to be on today's webinar, is understanding the snapping hip. So things that aggravate Lena's snapping hip in particular, they're using the gesture leg. So in dance, we talk about a gesture leg. It is the leg that is moving through space. It's doing the passe, developpe, battement, and those kind of moves through space. And the stance leg is the one you stand on. So a lot of dancers will have greater symptoms of snapping hip on the gesture leg, and that's no exception with Lena. When she dances and she moves that leg through space, particularly that right leg, she is dealing with some snapping and some discomfort and pain. And typically that pain is going to cause some kind of compensation, like over-recruiting the tensor fascia lata in her case. So if you've ever felt that large bulge just outside of the hips in the front, that's the TFL. And the TFL, tensor fascia lata, I often call that the coffee muscle because it sounds like a latte, is the muscle that over-tenses trying to flex the hip instead of having a nice rotation and allowing the hip flexor to be able to lift that up smoothly. So that's one of the things that we see with her. In Pilates, like leg circles, teasers, scissors, even feet and straps, she was complaining of the right hip snapping when she goes into hip circles with feet and straps. So let's give you a little bit of some subjective insight here, right? So in the patient interview, one of the first things we talk about is I like to ask them what they believe is going on, right? By the way, that leads any of these case studies always are built on the Polestar critical reasoning model. I see some of your names on here, and I know you've also already registered for the online critical reasoning workshop that I'm doing live tomorrow evening. We'll give you some more information in the end, but a lot of this problem solving and the technique we use in our webinar come from the critical reasoning model. And one of the first things we talk about is our interview. So in interviewing her, asking her what she believes she should be able to do that she's not able to do, her first answer as a newly graduated Pilates teacher and certified is all of the Pilates repertoire, including long lever leg motions in mat work. So that was That's her challenge right now. Like she wants to figure out like how come Pilates didn't just solve my snapping hip problem. And so we're going to take a little deeper dive into that. And then when I asked her, what do you believe prevents you from participating in these activities? She says inflammation, decreased joint mobility were the two biggies for her. So she feels a little bit of, loss of fluidity and mobility in that right hip. So as we look at the objective measures, this would be from the doctor that she saw, the orthopedic doctor, and did a set of x-rays and showed a mild decrease of joint space, which means there probably is some arthritis, and that's very typical. She's in her late 40s. She's been a professional dancer, very fit, very active. That's not uncommon to have some degeneration in the hip, but doesn't seem to be the main problem. What did seem to be a commonality that we see, especially, you have to ask what came first, the chicken or the egg. Some of the best dancers in ballet are the best dancers because they have an excessive amount of external rotation. That typically means they have a hollow or shallow acetabulum, so that we often refer to as some moderate hip dysplasia. So it's shallow, and where the femur comes into the socket, there's a little more play, right? And so that often can lead to other types of problems. For example, we often see a lot of labral tears in professional dancers with shallow hip sockets. Those are the kind of things that we're looking at. When she did her real-time ultrasound, it was obvious that she had a very inflamed iliopsoas tendon on the right compared to the left. So we know that she has a shallow hip. We know that she has an inflamed iliopsoas tendon that is painful. And if you look on the picture here, what we're looking at right in the tendon, and I'm going to see if I can, there we go with the arrow. You can see that's the tendon that we're talking about. And the snapping is probably that tendon or the early part of the iliacus muscle rolling over the capsule or rolling over the bone itself of the pelvis. So there's a little bit of snapping going on there, right? Posture, as I said, was within normal limits. Active range of motion, she was limited in her hip flexion to 110 degrees. Typically, a ballet dancer, even us as Pilates teachers, we should be somewhere around 130 degrees or more to have that great mobility that is required in ballet. But she was not able to do it secondary to anterior pain. So again, thinking of something like the capsule pinching or possibly the in a lot of cases, there could be a bony spur, which she did not have, according to the x-rays, are common causes for that limited range of motion. And probably the most common cause is a torn labrum, right? Which we do not think that she has at this stage of the game. Hip strength was a 4 out of 5 in resisting hip flexion. So as I put away from the pelvis, she had a hard time resisting that pressure, and especially around 90 degrees, and she felt that was because of pain. Joint sweep is another test I do to test specifically for a labral inflammation or tear, and she did have pain on the anterior medial aspect of the hip. So that means closer to the groin, a little more superior, sweeping that femur around like you're stirring a big pot of soup with a big spoon. And that also would give me an idea that it could also be combined with a little bit of inflammation of that medial anterior labrum, right? Again, the ultrasound and the x-ray would not show that. She would have to have an MR or a magnetic resolution image to be able to see that. Upon palpation, she had tender and swelling over the iliopsoas tendon. So that again confirmed what we saw in the medical screening as well as the physical therapy screening. Before I go any further, I would love to ask you the question. I like to do this in the beginning because I like your input. So before the assessment, before we go into looking at her as a Pilates teacher or what kind of treatment we'd want to do with her as a physical therapist, based on the subjective information up to this point, what would you hypothesize Lena needs the most right now, right? So again, just thinking what we talked about, that she's complaining of her inability to lift her leg up against gravity. She has this chronic snapping hip. She has pain. She has weakness secondary to the pain. She has decreased range of motion secondary to the pain. What do you believe would be most necessary for Lena right now? And again, as I sort of think through this with Lena's situation, is how do we provide an environment? What does she need to be able to start the healing process or to start getting the strength to be able to do this again? I see some people popping things up inside of the chat. Some good answers in there as well. Melissa, let's go ahead and show it so we can talk about some of these answers. All right, so we're going to have a pretty full spectrum of things here, and I'm going to let you know that a lot of these things, it's going to be. I see rest showing up again and again, and what is it that we want to rest, and how do we provide that rest, right? So I think we're looking at rest will help reduce the inflammation. We want to be able to get those tendons to calm down in the front. How do we do that? Maybe some reciprocal inhibition. So some of you had things like glute strength, hip extensor strength, hamstring strength. All of those are things that can help cause reciprocal inhibition on the iliopsoas muscle and tendon. So those are really good things. I see a lot of things that are more therapeutic of reducing the inflammation. Those are all excellent as well. Different modalities, icing, rest, those kind of things. And we're going to be looking also, I would say, is some strategy. So there's got to be a reason why, here's somebody's danced for a long time. We're going to have to figure out a new strategy for her to be able to figure this out. So let's, some great answers in here. I'm looking at stretching psoas, gluteus strengthening. And right now we're going to talk about how do we get a release of tension and the habit or what she's doing. Now, remember, I also said that her tensor fascia lata was off the charts as far as tender and hot because she's been compensating with that for all of her Pilates exercises. So we'll keep looking at that. So based on that information, what functional test would you want to do with Lena? So functional tests are things that could potentially mimic things that are causing her problems. So she mentioned any kind of gesturing with her right leg and dance, any kind of exercises where she's supine, lifting her legs up like hundreds, teasers, those kind of things. What would you want to do to test and see what might be causing it, right? Sometimes we got to look at it, even if it's a little uncomfortable, to be able to make a decision of what their strategy might be and how we might be able to help them with it. So what are some functional tests that you would want to look at or that you would want to see in Lena's struggle with this hip flexor problem? And these are ways of us sort of hypothesizing before we gather the information. We have to sort of just take guess and look at things and make educated guess. And then we look at the test, we might see that there's some very specific things that can give us more information regarding what's going on with Lena's hip. Melissa, let's go ahead and show it. So I see some physical therapy test in there, like the Thomas test, which is a great test, looking to see if there is a shortening of the hip flexor. I'm looking at things like her actual dance, like a battement or leg circles. I love the idea of dead bugs and bent knee circles, sort of looking at something with a modified load, but looking at that. Ankle mobility and strength, foot position, good. So I would love to see maybe something like a squat. Oh, I just saw a squat pop up there. Very good. Look at gait patterns. Single leg stretch is a great exercise. And one of the nice things about the single leg stretch is if you push into the bent knee, right, you're actually increasing the stability of the torso to see if the hip flexor is strong enough to hold that other leg out there. Those are some great ones. Butterfly position, love it. Femur arcs with tabletop position. Yep, great. So a lot of these are things I was looking at. I'm going to let you just take a few more seconds to plop some things up there. Pelvic clock. I like pelvic clock because the pelvic clock sort of has the control that they would have of the pelvis. And remember, I'm a big fan of looking at the joints around the area that they're having a problem. So looking at the ankle dorsiflexion, the hip mobility in a squat. And in her case, that squat, I still think is going to be limited a little bit because of the lack of hip flexion that she has. So that's going to be a good one to find out if that's true or not. So a couple functional assessment tests that we wanted to look at. One was hip extension. So just laying on her stomach and being able to lift her hip up off the ground, her leg up off the ground. without the pelvis going into an anterior tilt. So to me, the hip extension was a really important one to tell me, first of all, does she have hip extension? You'd be surprised, especially in ballet dancers, how many of them have very weak hip extension. So what happens is the femoral head slides forward in that socket, and that causes a lot of the anterior disruption. If you think of, a lot of that old classical ballet posture, they almost didn't even have a buttocks. So they often were in a posterior tilt or pushing that hip anteriorly and increasing the amount of external rotation in their standing leg or gesture leg. So hip extension was a big one for me. I chose marriage proposal this time, similar to like the squat, but I wanted to see, what happened with the back leg. So having her right leg and back. And if you know marriage proposal, you're sort of standing in the splits, vertical splits, sagittal splits, and dropping one knee down to the ground like you're going to propose to somebody to marry you. And I love that test because it looks at things like ankle dorsiflexion. It looks at the relationship of the knee and the ankle. It looks at the relationship of the hip and the knee on the back leg. And that's what I was particularly looking for. And then I picked the hundreds in the pre, which would be with the knees bent. So all of you that were talking about 90-90, dead bugs, femur arcs, knee stretch with the legs bent, those kind of things. Awesome job. Very good information for us because we could see what her strategy is, even if it causes a little bit of discomfort. Sometimes we're afraid to look at what causes discomfort, but when we do, it tells us so much information that we're able to glean from that and help us in our decision-making process. And then I had the swan on there, and I also threw just a picture of the bridge. A lot of times looking to see if they have enough hip extension strength to be able to lift the pelvis up to a flat surface on the front of the hip, just like you see there with Nicole. So those were a couple of the functional tests. There's many options. You had a whole bunch of good ones. Let's keep going. What do you believe could help regain her ability to flex hips against gravity again? Right? We know that's the biggest challenge. So we're looking at this. We did the test. We found that she was had a real difficulty with her hip extension on the right. She had difficulty with any kind of active lifting up against gravity with a long lever, but with a short lever, she didn't seem to have a problem. So doing like the 90-90, she was fine. We also found that in doing the hip extension, she was cheating a lot with her back muscles. So you've seen this a lot of times when somebody's laying on their belly and you want them just to lift the leg up in extension, like you're getting ready to do a single leg pump or go into dart or into some of the prone exercises. She was not able to do it just from the hip. So I find that interesting. And so the question that comes to my mind, is she dealing more with the tightness and pain in the front of the hip that she can't engage the posterior muscles, or is she really weak there that a lot of the compensation and the load is happening on the anterior muscles of the hip? Let's go ahead and show the answers, Melissa. As we're looking at this is, bone rhythms. Love that idea. Love, love, love. Eric Franklin, I just saw him post something today where he said, Franklin method really improves your Pilates. And I would have to put 2 thumbs up on that. We love bringing Eric Franklin's work into our Pilates. Bone rhythms are awesome. Pelvic stability. Yep, I bet you there's some problems there. 3D breathing, soften the ribs down. I like that. Definitely some thoracic limitation and mobility, believe it or not. Proper core control and coordination against gravity, glute strength, concentric and eccentric control. Very nice. Strengthening the psoas bilaterally. And I'll tell you that I'm going to stay away from strengthening the psoas for a little while, just so I'll put that out there and we'll talk about why in a little bit. We do need to get her back able to do that, but how do we do that? And probably one of the most important things here is going to be modifying some load, right? So I like the idea that everybody looking at things like marching and bridging, where you actually create an extension moment in the back of the hip, and then we're just doing little tiny pulses of marching. Pelvic floor strength and balance, working with the fascial lines. I love it, getting out of thinking of muscles and thinking more of elasticity, of the anatomy slings that we talk about. Very good things to look at. All right. Excellent work. Let's keep moving on. So here's a couple insights, and I think this is going to answer Jim McDonald's question of What about the inferior glide of the femur? So Lena's limitation is related to a shallow acetabulum and her anterior displacement of the hip in the socket. So I could put my hand on the front of the socket and I could feel the head of the femur, a portion of it, sort of like we feel with our shoulder, but we shouldn't feel that with the hip, right? And so I could feel that the femur itself was pushed up into the pelvis and anteriorly, right? So you could imagine trying to do an internal rotation or hip flexion could be incredibly laborsome to that iliopsoas tendon in particular. And that if you compensate by using things like the rectus femoris and the tensor fasciae latae, you're going to end up with a jamming that femur into the socket. So that jamming of the femur in the socket and its displacement anteriorly were probably some of the structural things that were causing this repetitive irritation and overuse of the iliopsoas tendon to the point that it gets inflamed. And when it's inflamed, a tendon gets round. And when it's round, it snaps. It rolls. It rolls over the joint. It rolls over the capsule, and it makes a snapping sound. So by increasing the posterior glide of the femoral head, this will increase the internal rotation and will decrease the irritation across the anterior hip. So I want you to imagine this, right? Let's get the picture here. So here's the femur head. Here is the socket. And the femur head, if I'm standing up and externally rotated, is very big in front. It's coming forward, right? And I want to drive that back into the socket and inferiorly glide it. So that's what Jim was talking about, that inferior glide of that femoral head, to be able to get it to respond correctly when it goes into flexion. So if that leg's going to lift up into flexion, it actually has to spin posteriorly and inferiorly relative to the pelvis. Now, we talk about this all the time in bone rhythms and arthrokinematics, is that the two bones of the joint must move relatively in opposite directions. So in order for that femur to come up into flexion, when she's laying on her back or she's standing up, you can see the arm goes up, but it's like my shoulder has to go down and it has to spin relative to the socket of the acetabulum or the scapula. The hip's the same way. And that's what we were seeing with Lena, is that she was really jammed anteriorly, and just all these tissues around this area were very painful to her. All right. How can we help Lena regain her posterior glide, depression, and internal rotation of the hip? I want you to think about this. What kind of positions could we give Lena exercises that would reinforce the femur head going back and inferiorly gliding and internally rotating? That's the movement that she's missing. There's no bone spur. We know that. The only thing we don't know right now is if she has a labral tear in the hip. But even if she had a labral tear in the hip, I would still want to do the same intervention. I'm trying to take the stress off of the anterior medial aspect of the joint and to be able to create more movement for that femur head in the acetabulum, and in particularly in an inferior glide and a posterior glide. Just think about that. Think about some basic Pilates exercises that we have that could help us glide that femoral head posteriorly. Take a moment, answer the question. Let's see what we come up with. So I see knees stretch in neutral, knees up, okay. Single leg and RDL, raised RDL. Somebody give me a quick, I have so many acronyms in my head, I can't think of what RDL is. I see the one I'm looking for. I see a couple of them now. Quadruped. Quadruped is probably one of my favorite positions. Sitting back in quadruped, very good. Progressing to internal rotation. You know, I love that so much. And I do this all the time for myself with my own hips. But quadruped is a fantastic place. So that would mean things like knee stretch and other quadruped exercises would all be appropriate in this case, that we could be working with her long spring on reformer. Thank you for that, Jill. Appreciate that. So the long spring work on the reformer, great. So that's going to help the long spring on the reformer or on the trapeze table takes the weight off the leg. So that's going to be something we're going to talk about in a minute, of that graded load. Femur arcs, the same thing with graded load, like something holding the leg up or giving it assistance so she doesn't have to carry the weight of the leg. But these are all things that help glide the femur back. So let me give you and share with you this idea. So if I am in quadruped and I start with my knees way out and my feet together, right? That's equivalent to being externally rotated. That's going to be the easiest position for Lena, or some of us that have this problem as well, to be able to sit back into hip flexion. Now, when I say sit back into hip flexion, I'm saying I'm going to put a hot coffee cup or tea cup on top of your sacrum, and you just shift back in your quadruped without the pelvis tilting, right? So what that's going to force is going to force that femur to glide posteriorly, right? It's still in a little bit external rotation, so it's still easier. There's more space in there. So they do that a couple times. It feels pretty good. They feel the movement. Bring them back up into regular quadruped. Now bring the knees into 90 degrees, straight in sagittal plane. Legs right behind it, right? So they're just in what we'd call our normal quadruped. I have that that image again of the coffee or tea cup on the sacrum, and they're going to slide back, right? And they're going to go as far as they can. They're going to notice they can't go as far now as they did when their legs were turned out. So they're going to do that multiple times until they feel like they're starting to get some movement there. And then the most challenging one, and somebody mentioned this, which I was really excited to see, bring the knees together and the feet apart. So now we're internal rotation. Now, when Lena first started this position, she couldn't move at all. There was no gliding. She was stuck, right? But by doing the progression from external to parallel to internal rotation, she was able to start increasing the movement. Now, what had to happen structurally for that femoral head to glide back into the socket? So things that have to happen, things like the rotators have to relax a little bit, right? They have to relax and allow the femur to glide back. So that's why that quadruped position is great, because they don't have any work to do there. They can just relax in that position. And think of things like the piriformis, the gemelles, right? The obturators. Think of the glute med, the glute max, all being able to elongate and to accept that femoral head moving posteriorly. So very important activity. And once she understood that activity, she almost got rid of her snapping hip completely, except for the fact that the tendon was still inflamed, right? So we didn't solve the healing problem yet, but we were starting to work with the dynamic structure of that joint. So really important to get that posterior glide. All right. So now we're looking at what principle of movement, right? So principles of movement include breath, it includes mobility, it includes dynamic alignment, it includes control, and movement integration. For where we are right now, so we figured out that we could get Lena in a quadruped position, and we could start working towards internal rotation to literally get a structural change in her hip mobility, right? In that socket. Start putting your numbers in there and see what you think. If it's more of breath, alignment, mobility, control. And remember, all of these are important. They're all important. But where would you put your weight right now? Where would you put your money on what is going to should be prioritized for Lena to restore her hip flexion? Be brave. Put in there what you think. They're all good. You can't go wrong with any one of the 5 principles. All right. And I see this sort of battle going back and forth between mobility and alignment. I like that battle. I think that's a good place to be right now, is that we're able to get some more mobility in there and start getting some actual alignment. Now, I'm going to define alignment again. We use the word dynamic alignment, and we're often referring to congruency, aren't we? So congruency is meaning that the femur head is congruent with the acetabulum appropriately for that range of motion. So I like seeing these two battling it out of mobility and alignment, right? I think they go together perfectly for her. And of course, she's going to have to learn how to work in that new orientation, which is going to be the movement integration part. And then another big one, which I was surprised I didn't see more of, is control, because control is what she's going to have to develop to be able to use that new range of motion. Right now, she's too weak to be able to have the load on that tendon because of the inflammation. So we're going to talk a little bit about load in a second. But excellent answers. Very good. All right. So we're going to summarize where we are right now. So with Lena, the focus on functional activities is strengthening the antagonist and the synergistic muscles. So I think we all agreed on that. Like, let's get some strength into her hip extensors and her rotators, and get some synergistic strength in the core and even in the lower extremity. Let's get her to where she can walk and stand, first of all, without pain. So you can imagine in Lena's posture, one thing I forgot to mention, I always say that, dancers have good posture, but the reality is if they're too posteriorly tilted in their pelvis, sort of pushing the pelvis forward, that's not an ideal posture. So we want to let her feel like her pelvis is sitting on top. And remember, when you're sitting on top, the pelvis has to angle forward about 15 degrees to be able to be in a good vertical posture for a human being. So that's really important. And then we want to look at her being able to focus on gradually modifying the load anteriorly to be able to do her Pilates exercises. So that many of you use this. You said, let's use feet in straps or long springs on the trapeze table to be able to assist, or the springs on the pedal for the chair. Those are all things that can create assistance where she can move through a range of motion without having to over-recruit those hip flexors while they're healing. On the structural limitations, things we want to continue to focus on, things like posterior glide and internal rotation. We know they go together. If we can create that posterior glide and internal rotation, we're going to have more joint space. We're going to have more appropriate contraction of the anterior muscles as well as the rotators to be able to control that movement. I also know that she's going to need some myofascial release in the posterior hip, right? Because she's used to having everything pushed forward. I remember after having my hip replacement, I was doing some rehabilitation with a friend of mine, Brian, a physical therapist here in North Carolina. And Brian was having me do some Tai Chi exercises, right, to start rebuilding some of the rotators and stabilizers around the hip. And as I was doing that exercise, and I literally had almost no pain with my total hip replacement. I was amazed at how good I felt, how fast I felt well with that surgery. But after doing those exercises, I got an incredible amount of sharp pain right in the center of my butt. And one of the things that Brian said to me, he says, well, think about it. You had an arthroscopic procedure 20 years before you had the hip replacement, and they did what's called a thermal shrinkage. So what they did is they shrunk the capsule. They don't do that anymore with the arthroscopic surgery. But when I would flex or bend or squat, I did not ever have to use my hip extensors because I could rest on the anterior fusion of that capsule. So now that was gone after the total hip replacement. For the first time in 20 years, I was starting to use the posterior muscles of my hip, or the extensors and rotators of my hip, and that's why I felt that. So in Lena's case, similar, we want to start having that sensation of opening up that muscle, that whole muscle system and fascial system in the back, to be able to give room for that femoral head to glide back. I also think she needs some soft tissue treatment to flatten out that tendon. Some of you talked about things like infrared and other types of modalities and ice, all great ideas, just trying to give that iliopsoas tendon a chance to heal. And then strategic limitation, she needs to find a new strategy for hip flexion, one that is not overload the hip flexors and one that can be maintained over the years so she can teach Pilates for the rest of her life and continue to have a good, healthy lifestyle. So what exercises would you incorporate for Lena's Pilates program today? So this one, you get a free-for-all. You can put in as many answers as you like, but let's just fill it up. Let's just think of things that sort of fall in line with what we want. We want to decrease the load on the hip flexors. We want to increase the alignment of the femoral head in the socket. We want to strengthen up the posterior muscles. We want to provide assistance to the hip flexors. What are some exercises in your repertoire that you believe right now would be safe for Lena to do without further aggravating the hip flexor, but actually progressing her towards a healthier and stronger hip and hip mobility? I see some nice things in extension, knee stretch. I like that. Bridging, I like scooter. Yes. Leg springs for frog and circles. And again, I would go with heavier springs than lighter springs, right? So the progression for Lena as she gets stronger and stronger is going to be lighter springs. Footwork on the reformer and chair, just really working on dynamic alignment. On any of the closed chain activities, we can be working on the bone rhythms, right? I saw the elephant on there. That's a great exercise. Again, thinking of that femoral head posteriorly gliding, femur arcs, knee stretches, up stretch, elephant, knee stretch, good. Parallel heels, bottom lift. I see some good exercises popping up there. Way to go. And so a couple of things that I'm seeing, the pattern in here are beautiful things of um, closed chain activities that can be progressed from externally rotated to internally rotated. So I like that. I like all of the assistance work that is going to be in supine and the active work that is going to be done in prone. So I'm seeing some good patterns here, and these are all very good exercises to be able to work with. And I guess the big thing here is thinking of how do we manipulate control by manipulating load to be able to increase the load of hip extensors and maybe for now decrease the load of the hip flexors. So when you think about our beautiful Pilates environment, we're able to really go through a lot of those things. Let me see if I'm missing anything here on the double leg, prone single leg stretch. Good. I like those. I love the idea of things like single leg stretch and double leg stretch. I saw that in a couple of yours. Side lying, clamshells, working on some rotators. I also would love to see her doing some more stuff in standing, where maybe she's doing just a small semi squat kind of thing, not even a 50%, but just sort of weight bearing from leg to leg, or maybe doing some proprioceptive things to start building up the strength. It was Christopher Powers from USC that talks a lot about how important glute, abductor, and adductor strength is for knee pathology, but it's also important for hip pathology. So when we were restoring that, great information. I do have a comment here, and it says, I've seen you put pressure into the hip joint of a supine client when knee was at 90 degrees to help release front of the hip. But this seems like it should be avoided with this because of her inflammation. Is that correct? So that's a great comment and great question. I don't know whose name is on there, but it's fine staying anonymous. The In this sense, if we were doing a 90-90, right? So she's in a tabletop position on the trapeze table, is a very safe position to do a posterior glide, because what we're trying to do is just not load the anterior tendon. So I would put my hands over the knee and just gently start putting pressure down to get the femur to go posteriorly. Now, most people that have anterior tendon problems of the hip, like this snapping hip, are going to like that move. The ones who would not like that move could be those that have a labral tear. So again, we have to be very careful if we have somebody that has a bucket handle tear or a major tear, full thickness tear of the labrum, that they might not like that. But we would know that the things that should feel better are not feeling better, and we would refer them back out to a medical intervention to see now what she would be up for next is an MRI. We try to avoid doing that unless we really have to do that. But a great comment. So I love the 90-90 posterior hip glide. That would be an excellent exercise, I believe, for Lena. So I would do that, and I would just be careful with it. So that leads us to the next and one of the final questions is, what precautions would you take with Lena pertaining to the inflamed iliopsoas tendon? Now, a lot of you have already answered this, but what are some things you would make special concerted efforts, like in the Pilates repertoire, requires so much hip flexion if we're not careful? What are some things that you could do as the modifications or the precautions that you would take with Lena to help her avoid further irritating the hip flexor, even though she's doing a whole body workout in the Pilates studio? What are some things you would think of? Some answers here off to the side as well. Jillian, squats or plie, standing on turnout disc, assist with arm springs. Yeah, that was the standing one, right? I love that kind of stuff. And being in a little bit of a squat actually helps get that congruency in the hip too, rather than being on straight legs. Good. Avoiding excessive flexion with single leg, double leg stretch, absolutely. And again, thinking of maybe doing certain exercises first, that Jill's talking about, certain exercises that really help with alignment first and congruency. And then we progress into assisted movement in the other direction. Let's go ahead and show the answers, Melissa. All right. Avoid activities that causes snapping. Yes. And again, I don't typically have a problem with the sound itself. I do have a problem in Lena's case where it's painful. So that makes it something that's a priority. You know, a lot of us, our bones crack and joints snap and those kind of things, and they don't have any consequence to them. We just are sort of noisy jointed as we get older. But if there's one that causes pain or associated with pain, that does create a precaution. Avoid excessive hip flexion, short lever exercises, keeping the alignment and less range of motion good. Avoid load with long levers. Yeah, we're all on the same page. And that's what I wanted to make sure we understood, is that we can provide a still whole body workout for Lena, but she just needs to learn herself that she needs to shorten the lever. She might need to use a little more assistance when the leg is in front of her. She should avoid things with long lever exercises in supine that would irritate that, and allow the body to gradually adapt. Now, remember, we always believe in adaptation. And so when we think of load modification, right? So load modification means that we are going to apply the appropriate amount of load for what they need at that time. It's an easy thing to state. It's very hard to do. And I'll be very clear with that. I still make mistakes. I either load too much or not enough on tissue. And we only know by trial and error. It is practice, right? So if a good guideline is, if we loaded the tissue for Lena's hip flexor, let's say she was feeling better, we're 2-3 weeks in, we're getting really good activation in the posterior hip, we're getting good strength, where the tenderness is calming down, the tendon is starting to flatten out again, the inflammation is going down, she's practicing good habits and good awareness. And we now want to start increasing her strength to be able to demonstrate and do the exercises, right? So let's say that we get a little ambitious one day and we decrease the springs of assistance maybe too much. And she then complains that the soreness lasted for more than 2 days. If soreness or pain lasts more than 2 days, that means we probably overloaded the tissue. And it happens all the time, and it's okay, right? We come back, ice it down, do the same things we were doing before, but we know we're going to go with half that amount of load or 2/3 of that load. And if Lena came back and said, you know, I don't have pain, but I feel sort of soreness, and it went away within a day, that tells us that the tissue is adapting. What I mean by that is the tissue is preparing to be able to handle more load. That's where the tissue becomes stronger, and it goes through basically a strain modification. If we just left Lena with restrictions to never do long lever exercises, never to straighten out her leg, never to do a full 100, she never will do it. She never will get the strength to do that. And so in that case, we don't get any change to the tissue. The tissue stays weak, right? And our goal is to have strong body in all planes of movement in all directions. Now, there are obviously some precautions that are lifelong precautions, things like maybe bone density issues, right? Or somebody that has a heart or a bleed issue as far as stroke risk or those things. We have to respect those all the time. But when we're looking at things like tendons and muscles and bones, a lot of times we must provide the right amount of tension to be able to get adaptation, to get stronger. So remember, the guideline is this. If we don't put enough tension on it, there's no soreness at all. If we put too much tension on it, the soreness lasts longer than 2 days, sometimes 5 days. And if we put the right amount of tension on that we're really trying to strengthen, we should see soreness for a day or two after training. So think about if you've ever done weight training. It's sort of that idea. So we want to be able to gradually progress Lena to the point that she can do those things again. And we've seen many people become successful at doing that, right? One of the precautions that I still have with Lena is whether or not there is a little bit of a labral tear in that anterior medial labrum of the right hip. And so I'm going to be a little extra cautious on that. I'm going to wait a good, 6 weeks before I start putting any kind of load on the anterior tissue and really focus on her having really good range of motion, very good dynamic alignment in the joint, strengthening up all the muscles around the area, working with modified ranges of motion and assistance in anything anterior, and making sure that she feels comfortable inside that joint, the swelling's going down. And then we might start, actively going after a little more range and a little more movement, a little more load in that anterior hip. I do have a question or comment that just popped up from Heather Peavy. She said, if you were doing the first exercise session with Lena, could you list your first series of exercise off the top of your head? Absolutely. So I would probably start, Heather, with just that quadruped work that we were doing, and just to see where she is, get a good baseline without aggravating that anterior tissue. I then would probably go to a 90-90, where I have on the trapeze table, I have springs around her thighs, I have springs around her ankle, and I just start doing some very gentle circumduction of the hip, maybe a little bit of force inferiorly that was asked earlier, seeing how that feels, seeing if she can have an increased range of motion by having the posterior glide and inferior glide on that femoral head. From there, I probably would go to something along the lines of another quadruped exercise, maybe on the reformer, and teaching her to work within a limited range of motion, maybe something like a modified knee stretch, maybe starting with the knees out in external rotation and then working a little bit more towards parallel. I also could work with things like even scooter in that first session, definitely some footwork. The chair would be top of the list for me in that first session, doing standing work and just setting the spring a little heavier than normal and having her lean into it and have to push down and changing the angles of the knee from a turnout to parallel. Again, everything focused on really driving that femoral head back. Then I would try to do something with some spring assistance, maybe still on the trapeze table, doing the Velcro straps around the thighs and doing some femur arcs once we know that we've gotten some deepening in that femoral space, and letting her just feel what it feels like to move that leg into hip flexion without pain. We do this a lot, for example, with the shoulder, and it's a little bit of a trick, right? So somebody comes in and they go to lift their arm up. This is the same thing that's going on with Lena with her hip. This is with the shoulder, right? So they're doing this instead of this. So what we do often is we get that tower bar, we spring it from above, we pull the tower bar down, we put their hand on it. And we tell them to let the tower bar pull the bar up, pull their arm up, and then pull it back down. And they start using the antagonist muscles. So they're using their lats and their serratus and pecs a little bit to pull it down. But then they're surprised that the arm is actually going into a full range of motion that they didn't have when they came in, right? So what's happened now is the antagonist has helped to seat the head of the humerus. That's the same thing we want to do with that femur. We want to get that femur head seated into that socket, into that labrum comfortably, and then it's going to perform much better. We're going to get a lot more range of motion. Then we can go with assistive motion, just like we did with the shoulder, to be able to re-educate those muscles right away, and also the psyche that she does have that movement and it doesn't always have to be painful. So that's probably where I would go in that first session. Great question. I have Daisy Armstrong asking, would pain in the pubic symphysis likely be connected to an injury like this, particularly in exercises such as side bend? So, the pubic symphysis is its own sort of beast. And we see this even a lot more with things like soccer players and martial artists, grapplers that have a real torque force that can cause a problem. Also postpartum, pretty hard on the pelvis. But that idea of the pubic symphysis. And again, you're looking at a cartilaginous material that connects into the periosteum of the pubic rami, right? So it's an inflammation and it needs to scar down, but it's not a real bloody area. So it takes a long time. So how do we create mobility in the hip and in the back to minimize the torque or stress that goes through the pubic symphysis. So that's the way I would look at that. And they can be, happen at the same time. You could easily have a iliopsoas tendon irritation and a pubic symphysis irritation at the same time. And again, I would be careful with things like splits. I'd be careful with things like single leg activity. I would tend to go more with double leg activity to try to keep the symmetry on the pelvis while the pelvis is healing if the pubic symphysis was involved. Leslie Mitchell asked, what are your thoughts on internal hip rotation on a 5-year-old hip replacement or a 5-year-old hip replacement? I thought you were saying a 5-year-old with a hip replacement, but a 5-year-old hip replacement that is having iliopsoas discomfort. So, on a total hip replacement, first of all, we got to know, is this a anterior lateral approach, or is it an old posterior approach? The anterior approaches, we don't really have limitations in these motions anymore. We used to, with an external or posterior lateral total hip replacement, we still had some precautions of adduction, internal rotation, and flexion, because that was how the hip was exposed during surgery. So I'd have to get a little more information, Leslie, before I committed that one. But I would say if it was an anterior or an anterior lateral, I would not have a problem going into internal rotation. Kim Taylor, can over-recruitment of the pelvic floor also cause the femur to move anteriorly? That's a good question. I don't really know if I have an answer to that. I think over-recruitment of anything can cause for displacement and just sort of functionally malalignment, right? What we are seeing a lot now, what we used to always think of as being a flaccid pelvic floor, we're really finding are hypertonic pelvic floors. So there's a lot of tight pelvic floors, I guess, going around these days. But that being one of the causes of stress incontinence, whole nother topic. But in line with your question, Kim, I mean, I think that, if you think of what often accompanies a Kegel, a Kegel also will accompany things like the inferior glute squeeze or the adductor squeeze, often can become part of that. So they certainly could have an effect indirectly on sort of the relaxed and proper fitting of the femur into the pelvis. And again, remember, there's the spectrum of hypermobility, and hypomobility is huge, right? So there are some people that are very, very mobile, and those that are not mobile at all. There's some that have shallow sockets, that have deep sockets. So most people, the hip is nice and deep and it doesn't really move around a lot. That's why those of us that came from the dance world, there is a bias of really good ballet dancers in particular that tend to have a more shallow acetabulum. So there is more joint play and there's more risk, but that's also why they're a better dancer, because they can make the lines with their legs, etc. There was another comment about aqua fit classes, and I think anything in the water is fantastic when somebody is in acute injury, because we can completely modify the load. Great idea. Lori Winslow says, I found clients with this usually have tight back extensors. Really, all posterior chain is tighter. Would release work on mobility work on lower back help? And this is that same thing I'm talking about. When you see a pattern of over recruitment, right? This is sort of where we talk about how many different joints and how many different neuromuscular systems can actually contribute to other problems. So decrease ankle dorsiflexion, decrease hip mobility, decrease thoracic extension, over recruited low back muscles typically will continue to seize up into the buttocks or into the adductors. You go down and touch their sit bones, right? Their sacrotuberous bones and ligaments, and they'll jump through the roof. Why? Because that whole posterior fascial chain is over recruited. And so we go in and we start increasing mobility, providing assistance, working on dynamic alignment. We see that stress come down. We're going to see better alignment in the hips, better alignment in the knees. And that's why, the reason why Pilates works so well is because we work the whole body. In physical therapy, we get stuck so often because we get a diagnosis that says you can work on this. This is the diagnosis. And we don't take the time to look at every other factor that influences. While they're on the Pilates reformer, trapeze table, or mat class, we can see, oh my goodness, they're way over recruited in their back, and they don't have enough ankle dorsiflexion, and they don't have good thoracic mobility. let's just treat those things naturally like we do in the Pilates class and see what happens to the pain they have in their hip. And a lot of times that hip pain is going to get better, right? I got two more questions and then we'll call it a day. I appreciate these questions. This is Jillian Egan says, if there is iliopsoas discomfort, but not quite yet full inflammation of the tendon to this degree, would you start the same way, and how to know if and when it is safe to strengthen what is likely a weak iliopsoas? So one of the key things is sort of a trick. The iliacus obviously is a one joint muscle, so it rests inside the iliacus of the pelvis. And when it shortens, it's going to bring that femur up and maybe a little bit of external rotation. But the psoas, which is a bigger muscle, at least a longer muscle, attaches to the anterior spine from about L3 up to T12. So if we do not have control of the trunk, we cannot have control of the hip through the psoas. So a lot of times that's where we see psoas pain becoming uncomfortable. We see a loss of hip extension. People compensate. That's why that hip extension test is a good one, because you can see if they lift their leg off the ground and their back doesn't go into hyperlordosis, then you know that they have enough range of motion in their iliacus and iliopsoas, right? But if you see them lift their leg up and you see their back go into hyperextension, then you know that there is a shortening, which often is accompanying sitting. So the longer we sit, you sit long, those hip flexors sort of print themselves into a shortened position. We have to have enough stability in the torso, especially with long lever exercise, to do that. So I would start, Jillian, in making sure that, things like they're able to roll up to the base of their shoulder blades. I'd make sure that they have good thoracic mobility, that they're able to do things like bent knee openings or knee side to side, or things like even getting into some simple dead bug exercises, right? Before, and making sure that they can control and maintain the origin of that muscle, which is at T12, L1, L2, L3. And if they can do that, then we can start gradually loading, as we said, graded load onto that hip flexor to strengthen it, especially if it's not really inflamed. Great question. Last one, Patty Posios. I hope I said that right. What about footwork on the tower? The load pushing against the spring from below would push the head of the femur into a hip socket. Yes? And the answer to that is yes. I love that exercise. That's a great one. I didn't bring that up, but I appreciate you bringing it up. That's a great way for us to finish the discussion today. It's just there are so many ways, and you have all these tools at your fingertips as Pilates teachers and physical therapists in the Pilates realm that can use the movement, the forces, the gravity eliminating, the spring assistance, the closed chain, pseudo closed chain. All of these tools are so powerful for helping people to reorganize their body and to find the new them and to return to participate in the activities they want to participate in. So keep up the good work on that. This is great. I enjoyed the discussion today. If you're interested in a little more in-depth discussion, join me tomorrow afternoon. It's a very low cost. We have people joining us from all around the world. It'll be a 3-hour workshop in the afternoon. Would love to see more of you there, and we'll go from there. So again, lots of things happening. Check out the Polestar website. We're grateful for your time, and above all things, please be kind. Let's make this world a better place, increasing awareness and consciousness of everybody around us, especially us. Thank you.